My name is Professor Simon Rogers. I'm a maxillofacial surgeon here at the Aintree University Hospital. The PCI is a collection of 57 items that have been chosen by the patients, the carers, the multidisciplinary team, the regional network, in collaboration. 57 items that patients might want to discuss, might have as an issue when they come to an outpatient consultation. Also within the PCI, there's 17 people, part of the MDT, who they might wish to have access to or be referred on to get additional support. The PCI works in two ways. It works as a paper checklist approach, which the patients can fill in the outpatient clinic area whilst waiting for their consultation. They can then bring the PCI into their consultation. The other approach is to have it computerized through touchscreen technology. In that approach, the patient is invited to take part in the PCI process. They are taken by a volunteer to a separate room, and there they complete the PCI using touchscreen technology, identifying the issues that they may want to talk about in their consultation, identifying those colleagues they might want to see. At the end of that process, and that normally takes around about 8 minutes or so, at the end of that process, a print-off takes place where they can bring into their consultation a print-off of what they've identified as being their important issues, or alternatively, it's possible to network it into the consultant's room via computer if you don't want to go and have a printed version.
Okay, Barbara. So you've ticked down dry mouth as being an issue in your patient concerns inventory.
Yes, it certainly has. I do have a spray that I use, but unfortunately nothing lasts for very long. I do have saliva, but it's mainly of a night that I have the problem. Okay. Sometimes I may get...
The benefits of the PCI for patients is that they are given the opportunity to raise issues or concerns that are otherwise easily missed. For whatever reason, they come to a busy clinic and they go into a consultation room and they can forget to raise things that they want to talk about. They might feel slightly intimidated and feel they haven't got the mandate to raise certain things. They might just feel that the clinic is too busy and it'll be too much of a bother to raise things. And all too often, there's issues going on for a patient, particularly after something as significant as head and neck cancer, where there's a whole range of issues that they might want to talk through, and yet they don't use that opportunity to discuss that in their consultation or get onward referral. So the PCI acts as a mechanism, as a tool to allow the patients to raise issues that otherwise would be so easy to miss.
And you're happy with what the consultation was?
Yes, I was very happy today with everything.
Okay, we're just going to take you to the desk, make an appointment, which might come on the post, but then again you might be able to make it now, so let's come and find out.
That's fine, thank you very much.
Yes,
yes, we understand everything, thank you very much.
We'll just take you to the desk now, you can make the appointment.
The PCI has influenced my practice by signposting patients to me, and they come from a variety of sources: consultants, doctors, clinical nurse specialists, nurses on the ward, sometimes even the GPs. The patients come to me with a variety of issues: stress, anxiety, disfigurement. They also bring issues not related to the actual surgery, emotional problems in their families, secondary issues that they also bring, not up front.
I find using the PCI very helpful within the clinic setting, because as a physiotherapist, it allows the patient to identify what issues they want to discuss with the consultant. Also, as a physiotherapist, it allows the patient to identify physiotherapy as a treatment option that they wish to be referred on to.
I input to the weekly clinic here on the maxillofacial unit, and we're using the PCI as a way of identifying patients who may need any input in terms of speech or swallowing, I do routinely see patients for follow-up, but sometimes there's a risk that these patients might be missed. They may not have had surgery on the ward, they may have had different treatments, which mean they haven't come across speech and language therapy. And I see it as quite a powerful tool to signpost them to speech and language therapy if they're having any problems with speech or swallowing. By presenting them with these options in the clinic, they can identify any issues and whether they want to see a speech and language therapist, and I can then either be called into the room or arrange to see them on a separate basis to see the nature of their problems and any interventions that I can offer for them.
The PCI enables patients to prioritise their concerns, and those concerns may not be around their cancer or their treatments. There are lots of other things that are affected by somebody having cancer. That means the staff within the clinics can then direct people towards our Macmillan centres, and we can provide that support and information that they need. At the Macmillan centres, we have an enormous range of information, of leaflets, not just from Macmillan, but from various local agencies, from other national agencies that can support people. We have a benefits advice session, and we have complementary therapies which are available free to the patients here at Aintree. So we would hope that we would be able to meet any need that they're identifying by using the PCI.
Colleagues have responded really well to the PCI approach. I think they've recognised that patients can need a bit of help in raising issues that are a concern to them. The consultant colleagues can use the PCI in a way that they can help identify issues and target people and signpost people to certain colleagues. The multidisciplinary team have found it very useful because they have the reassurance that they can get patients identified with particular problems that otherwise would be missed. So the nursing staff like the whole idea of the holistic approach for patient care, and there has been some concerns about bringing the PCI into clinical practice. It may make the clinic work slower and longer, but what we've actually found is because the clinician has certain issues they want to bring into the consultation, and the patient then is focused as to what they bring into the consultation. In fact, the whole consultation process is streamlined, the communication between the patient and the professional is much clearer, and in fact, rather than slow down consultations, if anything, it's really acted as a focus for the consultations to make them go through in a very timely manner. The PCI has been used in its head and neck version in various places across the world now. It's been developed in South America, there's a unit trialling it in Florida, there's been some work in Malaysia around the PCI head and neck, and in fact probably the most encouraging new future event that's coming forwards is in Dundee. They've been building it into an eye app for better technology and with the use of computers. Also, in terms of the PCI philosophy, there's some colleagues have evolved it and adapted it, created different items. So it's been used and developed in breast cancer, in brain cancers, and in rheumatology. And there's various other interested clinicians and specialty groups that are interested in developing the PCI approach further for their specific needs. My personal motivation over the 5 years or so of developing the PCI is that I've realised the limitation of health-related quality of life questionnaires. Health-related quality of life questionnaires are used in clinical practice, however they are limited by the number of items they cover and also the wording of the questionnaire, and it sort of comes up with a score. And I was trying to develop the quality of life questionnaires to help identify patients' needs, and it didn't work, and hence we moved forwards to develop the PCI to make sure the patients have that opportunity to raise issues that they wouldn't otherwise raise in the consultation. With that, they can then get access to support and therapy, and in fact there's evidence to suggest that even if we just talk about a certain issue in the clinical consultation that they feel is important, that's therapy in of itself. So Anne, how are you doing?
I'm feeling very, very well, thank you.
Because you're 18 months post-treatment now.
Yes.
So time's gone by for you.
It has, yes.
And everything's fine. Family okay?
Yes, everybody's really pleased with how I've recovered.
And I've checked you over, so there's nothing of any nastiness. There's nothing to worry about.
Oh, that's good.
In that sense. So if you're into this second year, we still sort of keep going for reviews every 2 to 3 months, if that's okay.
Oh, I'm happy with that, yes.
Is that okay?
Yes,
all right
that's
then. Is there anything else?
fine. No, I don't think so.
Oh, I just noticed on the PCI, on that computer thing that you did before we came in, you mentioned hearing.
Oh, yes. Oh, I meant to bring that up, actually, yes.
Okay. What have you noticed with the hearing then?
Well, it's the family really. They're saying that I've lost some of my hearing in my left side.
Okay.
And they've noticed that I'm turning the television up a lot louder than I used to.
So
it's annoying them.
You turn the television up and it's annoying them, and that's something that's come on recently, or since the surgery?
In the last few months, they've noticed it, and now they've told me I've begun to notice it a bit more.
Any pain or discharge or dizziness or anything like that?
No, there's nothing like that.
And it tends to be on one side rather
just on this side, yes, just on my right side.
You had surgery on that side, and there's a tube at the back there called the eustachian tube, and sometimes that starts to misbehave and gets a bit blocked, so you get something like glue ear. Now, have you heard of glue ear, like children get?
Yeah.
And if it was okay with you, what I would do is I would suggest our audiology department to see you.
Right.
They can run some hearing tests, work out what's going on, and take it from there.
So does that mean it could stay like it is and I've lost some hearing?
Well, sometimes patients can have a grommet put in, like as youngsters do. Sometimes they can have simple medicines. Sometimes it's a matter of a hearing aid. But what you need next is a formal hearing assessment, really, to work out what's causing you to be a bit deaf on that side.
Okay, yes, I'm happy for
Is
that
that okay?
to happen, yes.
So what we can do then is I'll arrange for the audiology department to see you, and we will then meet again in about 2 to 3 months. If you haven't heard from the audiology department in the next couple of weeks or so, give my secretary a ring, just make sure we're on the case.
Will do, yes, I'll do that.
Is that okay?
That's fine.
Anything else? You're okay?
No, I'm fine.
Okay.
No, thank you
Great.
very much for
Pleasure.
what you've done. Thank
Okay.
you.
Pleasure.
Thank you.
Great. Hello, Barbara.
Hello, Doctor.
So it's 6 months now since you completed your treatment, isn't it?
Yes.
How have things been?
Not too good.
Not too good, yeah. I noticed that. You've had a chance to do the computer system before coming in.
Yes.
Yeah, and this is what it is in front of us here.
Yes.
And I noticed you've ticked all sorts of issues, really, my love.
Mm-hmm.
You know, the dry mouth, the pain. What's the pain aspect to it?
It's my shoulders.
Your shoulder.
Shoulders.
Your taste. The peg tube, the feeding tube isn't working very well.
No, Doctor, it isn't.
In what way?
It's just not working.
It's not you, is it?
No.
And then there's the speech or the family support, coping down, depression, memory, mood, personality and temperament you've ticked as well.
Yes.
Okay. And what often that means to me is when somebody's ticking a lot of things, I haven't got time in a busy clinic to go through them all. Also, I'm probably not the best person to go through them all. And what my suggestion is, if you didn't mind, in the clinic today, if I just ask our clinical nurse specialist to see you, they could spend a bit of time just unpacking some of these issues, trying to work out what support we can get for you, and where we're going, trying to get beneath the surface a little bit.
Right.
And that'll be much better, I think, for you to have somebody else just have a quick look at you at this stage in your cancer journey. And if I can ask this clinical nurse specialist if she's got time to see you?
Yes.
Would that be okay?
That's fine.
And then afterwards, if there's any issues that she needs to bring up or you want to bring up, I can see you again. And I must just confirm with you, there's no evidence of the cancer being back, okay?
Right.
So I've had a look round and that's all okay. And I just think there's a few issues here that we ought to just try to help you with. Yeah. And I think our clinical nurse specialist will be the best person for that.
Right, Doctor.
Is that okay?
That's
so we
fine.
will then meet again. If we don't meet again later in the clinic, we will meet again in 6 weeks' time.
Right, Doctor.
Is that okay?
Yes,
and now
fine.
I'll get Sally to see you.
Right, that's fine.
Okay,
Thank
my
you.
pleasure. Great. Hello, John. Good morning.
Good morning.
How are you doing?
All right. It's fine after the operation. It really
it's about
is.
a year, isn't it?
Just over a year,
over
yes.
A year.
Just
Okay.
over a year.
Yeah.
But I tend to worry about whether it's popping around somewhere in my body.
Okay.
You say it's gone, but I think, could it pop out somewhere else as something else?
So I noticed on the computer screen, you did that before you came
Just
in.
before, yes.
You've ticked two things.
Yes.
One was the fear of the cancer coming back.
Yes.
And the other was the shoulder.
The shoulder,
okay,
yes.
Since the surgery.
Yeah.
So if we've got the opportunity just to focus on those two aspects,
yes.
If that's okay, shall we do that?
Yes, yeah, sure.
So just the fear of the cancer coming back, how often are you going down that sort of route?
Usually at night.
Okay.
I wake up in the night and thinking, what's going on?
Okay.
Is it going to come back? Because it's pretty major.
And is it sort of cause you to lose sleep?
I do lose sleep, yes.
Every night?
Most
every
nights.
week?
Most nights.
Most nights,
yeah.
Okay. And is it associated with things like pain or anything like that, or is it just something?
No, I think I just think about it. But I do get a pain in my shoulder.
Okay. Just in terms of the cancer coming back, and the pain in the shoulder is due to the surgery.
Yes.
So that's not the cancer coming back. It can't be. It's not related to that.
Yes.
But the cancer coming back is a real concern.
It's
natural.
Yes. Yeah.
And of course, anyone who's been through that experience, I'm sure, must, to a certain extent, worry about those sorts of things.
Certainly do. Yes.
Yes. I just wonder how intrusive do you think it is? Because it might be worthwhile us asking, if you wanted, to see the emotional support therapist, just allow you to talk through these anxiety sort of issues.
Well, if you think they'd do any good, yes, I would. I'd see somebody. Because I don't get a full night's sleep these days.
Okay. And it sort of plays on your mind.
It plays on my mind. Is it going on again?
We'll be meeting again in another 6 to 8 weeks.
Yes.
So in the meantime, I could ask our emotional support therapist to see you and see where that dialogue takes you and see how much more support. Yeah. I have examined you. There's no evidence of the cancer coming back.
Good.
And in fact, your treatment was just surgery alone without needing radiotherapy.
Yes.
So the chance of the cancer coming back is very small. I just want to reassure you in that regard.
That's good.
You know, we've got an 80% cure rate.
Right.
But I can just think for some patients it is natural to become a little bit more preoccupied about that issue of the cancer coming back.
Well, I do feel reassured on that then.
Okay.
I mean, if I can sleep better, that'll do me.
Okay. And then the shoulder side, what have you noticed with the shoulder?
When I'm driving, I'm tending to drive with my left hand now because my right hand, when I lift it up, it starts to get pains.
Okay. And that can be due to a nerve that goes through the shoulder called the accessory nerve that's part of the surgery.
Yeah.
Have you seen the physiotherapist?
I've seen nobody.
Nobody?
No, it's the first time I've mentioned it.
And the shoulder side, has it been there since the surgery and he's just noticing it more as you're driving and doing things?
Well, I notice it more when I've been driving for some time. My arm starts to ache.
Okay. So again, I probably, if you didn't mind, my suggestion would be that I just flag it up with our physiotherapist.
Yes.
And either next time you come, or if it's mutually convenient, to arrange another appointment, just specifically with the physiotherapist, he could see you, make an assessment, give you some advice, and see where that takes you.
Yeah. Oh yes, fine.
Would that be okay?
That would be great. It really would.
So the fear of the recurrence, the shoulder. Is there anything else you want to talk about at all?
Not really, I don't think. No, they were the two main things that I put on the form.
Okay.
So it was fine.
So if there's nothing else, you sure?
Absolutely, everything's fine.
So I will organise those two appointments for you, and I'll see you back here in 6 to 8 weeks' time.
That's fine. Lovely.
Okay.
Thank you very much.
Great.
Thank you.
Good.